Hello and welcome everyone. We are the Oncology Brothers, where the focus of our conversations is to bridge the gap between community and academia in this rapidly evolving space of oncology. In this episode, we will be taking a deeper dive into the data on extensive stage small cell lung cancer, particularly focusing on IMforte data and its clinical implications. I'm Rohit Gosain, and as always, I'm here with my brother and co-host Rahul Gosain.
Rohit, IMforte data, which is the use of Lurbinectedin and atezolizumab as maintenance treatment in frontline settings for extensive stage small cell lung cancer, was initially presented at ASCO 2025. And right away, we saw overall survival benefit with this. But since then, we've also seen some updates at World Lung 2025. And just days ago, this is now also part of NCCN guidelines. So this indeed is now the new standard of care. To take a deeper dive into data, today we're joined by three thoracic medical oncologists, Doctors Isabel Preeshagul from Memorial Sloan Kettering, Dr. Ticiana Leal from Emory, and Dr. Stephen Liu from Georgetown Lombardi Cancer Center.
Welcome everyone. Let's dive right in. There's quite a bit to cover. Isabel, I'll start off with you here. If you could please outline the study design for IMforte, especially the patient population that was included in the study and how lurbinectedin was incorporated as a maintenance therapy.
Absolutely. So just to give a little background, we have 3 approvals in the extensive stage small cell lung cancer space. We have carboplatin, etoposide, and atezolizumab, which is the Empower 133 regimen. We have carboplatin, etoposide, followed by with durvalumab, which is the Caspian regimen. And we have the newly presented IMforte phase 3 study looking at carboplatin, etoposide, and atezolizumab, followed by atezolizumab and lurbinectedin maintenance. So let's go over the sort of the study schema first. So this was a large phase 3 study that was looking at patients with newly diagnosed extensive stage small cell lung cancer with no prior treatment. They went on to receive 4 cycles of induction therapy, which is carboplatin and etoposide and atezolizumab every 3 weeks for 4 cycles. And then if they had stable disease after those 4 cycles or even better response, they were then randomized to receive one of 2 therapies. One was atezolizumab every 3 weeks as maintenance, and the other was atezolizumab every 3 weeks as maintenance, plus lurbinectedin at 3.2 milligrams per meter squared every 3 weeks as well. And these maintenance cocktails were continued indefinitely until there was progression of disease or intolerability.
Isabel, thanks for walking us through. One thing that I do want to bring up here, within the study design, we also had primary prophylaxis with growth factors for all our patients in terms of the maintenance to help with neutropenia. Stephen, this study got a lot of attention at ASCO, and since its initial presentation, it was quickly adopted in our day-to-day practice because of that overall survival here. Can you walk us through the data from ASCO and also touch on the recent update from World Lung 2025?
Yeah, happy to. So we know lurbinectedin is an active drug that's been approved in the later line setting. It had activity in platinum refractory and in platinum sensitive disease. We've used it in the second line setting for many years. And so it's an active drug. So before the first patient's enrolled, what do we expect from adding this drug in the maintenance setting, from moving this up earlier? Well, compared to just standard immunotherapy alone in maintenance setting, we would expect some more responses. We would expect an improvement in progression-free survival, and we would expect an increase in toxicity with an active drug. But the big question is, would that translate to people living longer? And what we saw is that it did improve PFS, it did increase responses, it did add toxicity, and fortunately that did translate to an improvement in overall survival. If we look at the PFS benefit, what's the degree of benefit here? Adding lurbinectedin to the maintenance setting improved progression-free survival from 2.1 months with Atezo alone to 5.4 months with lurbinectedin and Atezo. That's a PFS hazard ratio of 0.54. It's a pretty impressive improvement in PFS. Now, if you first look at those numbers, you might say Atezo alone, the PFS of 2.1 months seems low. Seems like it underperformed. But the way this study was done, we're actually measuring from randomization at maintenance. So we're not including the 3.2 months of induction therapy. So if you take that 3.2 months of induction plus the 2.1 months with Atezo alone, that's going to put us at 5.3. And that's really what we saw with Empower 133. Atezo PFS, the PFS was 5.2 months in that study. So remember, we're adding 3.2 months to the absolute numbers if we want to compare more apples to apples. I think the hazard ratio, though, of 0.54 is telling. If we look at landmark, if we give maintenance Atezo alone, so we finish induction and we do maintenance Atezo alone, at 6 months, 19% of patients were progression-free. That's the small number, 19%. With lurbinectedin and Atezo, that number goes from 19% to 41%. We over double the number of people that are progression-free at 6 months. And I think it's important to give patients that period of time where their disease remains under control. So we have an improvement in PFS with a hazard ratio of 0.54. But what moves the needle here is survival. Does that translate to people living longer? And it did. We saw an improvement in overall survival from 10.6 months to 13.2. Again, 10.6 with Atezo, add that 3.2, and that gets you, closer to 13. That's much closer to what we saw in Power 133. But you're going from 10.6 at maintenance to 13.2. That's a survival hazard ratio of 0.73. Now, if the OS hazard ratio of 0.73 sounds familiar, it's because that's the same hazard ratio we saw with Caspian, the same hazard ratio we saw with Adriatic. This, we know, is a clinically meaningful improvement in survival. While the absolute numbers are lower because it's extensive stage small cell, the relative gain is the same. An OS benefit with a hazard ratio of 0.73, an increase in the 1-year survival rate from 44% to 56%. So this is a gain. We see an improvement in response rate. And again, we kind of reset at the time of maintenance, so we do see more responses, but we also see an increase in toxicity. Now, your point, Rahid, is very, very good one, that we were giving primary prophylaxis with pegylated G-CSF because of hematologic toxicity. And what we do see is we do see more heme toxicity. If we look at the tornado plot overall, we see lurbinectedin side effects. We see more nausea, fatigue, we see anemia, we see neutropenia. Most of these are low-grade toxicities. And the word tolerability, as Iz always tells us, is one that's really subjective and one that we should try to avoid as physicians. But one objective measure we can look at: how often do people stop any part of treatment due to toxicity? How often do we stop therapy because of side effects? And that number was 6%. It's a pretty low number. So 6% of patients stopping treatment due to toxicity. The data were updated at WCLC at Barcelona by Dr. Martin Reck. And what they showed was that most of the adverse events we're seeing with the addition of lurbinectedin are grade 1, 2. They typically occurred in the first 9 weeks of therapy. And once we got past that first 9 weeks, new adverse events were much less common. Dose interruptions were seen with lurbinectedin, but these were mostly driven, as you'd expect, by hematologic toxicities. And again, the rate of discontinuation of any drug was very low in both arms. So really toxicity, a little front-loaded, mostly hematologic. A lot of these are paper toxicities or lab abnormalities, not necessarily patients feeling this. The rate of discontinuation due to adverse event, fortunately, was very low. So clearly an advance, an improvement in survival, and something that we really should consider for our patients to improve their outcomes.
Well, thanks so much, Steven, for summarizing that. There's quite a bit to unpack here, and these are, again, exciting times for our patients and also medical oncologists. Small cell lung cancer historically has been a hard disease to treat, and we are now finally seeing, as you stated, the overall survival here with a hazard ratio of 0.73. Ticiana, initially when IO was approved in small cell lung cancer, as Steven said, that we had seen similar hazard ratio, what we are seeing that is in addition to lurbinectedin. This was a maintenance trial, so this overall survival benefit is in addition to what we've seen in the past. Can you please help us, in the context for our patients and us as medical oncologists, what should this data mean to us?
Yeah, I think this is, a trial that clearly is showing that there is clinically significant improvement in terms of the outcomes of progression-free survival and overall survival. And I think this is, as you stated, a very difficult to treat disease. And while we had gains from immunotherapy and immunotherapy in combination with chemo and maintenance, that benefit was modest, but also meaningful. And this builds upon that. So again, this is a study that is from randomization. We're calculating the overall survival, so we do have to take into account induction. And so this is a difference that's meaningful. It's definitely a gain. We're seeing here 13.2 months, adding the induction, as Stephen mentioned, add an additional 3.2 months. So certainly I think for our patients who are fit and eligible for chemotherapy at maintenance, I think this is a strategy that offers improved outcomes. Certainly having to balance side effects and quality of life and having that discussion with patients. But I think overall we're very accustomed to managing side effects from lurbinectedin. As previously stated, we've been using it in the second line and beyond. And so we've been accustomed to managing the side effects of lurbinectedin. And importantly, I think here there weren't any sort of synergistic effects in terms of side effects when you added it to immunotherapy. There was an increased risk of immune-mediated adverse events. So again, no signals there in concerns, but certainly having the discussions about managing side effects and being proactive. And certainly I think the growth factor is an important component of managing.
Ticiana, I echo what you said. Any survival here in this disease is meaningful. And we'll switch gears to talking about side effects. But before we do that, Stephen, this data was adapted shortly after its ASCO presentation. And now it's also part of NCCN guidelines. I think it's fair to say that most of our small cell lung cancer patients should receive this. So I think broadly, if you're using it, an important question would be, who is perhaps not the right patient for this approach?
It's a good question. In the study, to be eligible for that randomization, you had to have recovery of hematologic parameters. So you needed to sort of see that CBC come a little closer to normal. You had to have no progression, importantly, and still a good performance status. So I think we'll know them when we see them. Certainly if someone's progressing, we don't talk about maintenance therapy. We talk about second-line treatment. It really would be a different strategy. But if patients still feel well and if the blood counts have recovered, it is something I think we should consider. If patients are still prolonged cytopenias, neutropenia, that hemoglobin just not coming back up, maybe someone with underlying MDS or some poor marrow reserve, this might not be the ideal strategy. If someone is just too frail after therapy, which does occur, this might not be the best strategy. We don't want to do any harm. But if patients are feeling well, which often they are after we get that initial response, then I think it really should be considered and offered.
Absolutely. And again, in second line, we have lurbinectedin as a single agent and also tarlatamab. So if the disease was to progress, we lean into those second line treatment options.
Well, talking about the side effects, this is a good segue to touch on that point, and importantly, how to manage them. I know we talked about the prophylactic growth factors, which was part of the trial design when it comes to neutropenia. Isabel, with lurbinectedin now combined with IO as part of maintenance, what can we expect in terms of the side effects and how to manage them? Some clinical pearls around that, please.
Sure. So yes, I think we've spoken about the neutropenia or just cytopenias in general that develop from induction chemotherapy, and our hope is that patients will recover some marrow reserve from that. But we do see neutropenia, we do see cytopenias, we do see that includes anemia, thrombocytopenia, and neutropenia, so all cell lines. And I think it was about 73% of patients that continued the G-CSF prophylaxis going into the maintenance setting upon randomization. And I do think that this is standard practice. Even in the second line setting, it is recommended to if you're giving lurbinectedin, to offer G-CSF support, given its known baseline myelosuppressive effects. So I do think that this is not a surprise, and I do think that this should be standard practice. The last thing we want is to have a patient get admitted for neutropenic fever or to have to dose reduce because of neutropenia, not because the patient is not able to tolerate it or having other side effects. So I think if we can, get ahead of things, that might be a good thing to do and just sort of be proactive rather than reactive. So I do agree with that. And while there were grade 3 and grade 4 toxicities, I don't think there was anything that was unexpected. When looking at the tornado plot, as Stephen had said earlier, I think we saw fatigue, we saw nausea, and we saw cytopenias as the main side effects. There are other more rare side effects that can happen. I think there's rhabdomyolysis, which is reported. And I actually have had a case of that that I inherited, which is unfortunately devastating, but can happen, but manageable. And if you keep your eyes open for it, I think that's something that you need to be aware of. But these are manageable, and we can be proactive about these things. And I do think that with the right support and with the right knowledge going into it, you can support your patients. And I do think that this is the right regimen to go ahead with for the right patient.
It's important to keep all these side effects in mind, but thankfully, as you stated, Isabel, that discontinuation due to toxicity in IMforte with lurbinectedin was rather low. Ticiana, any additional thoughts with regards to managing these side effects, especially when you get started the patient on 3.2 milligram per meter square? Do you dose reduce to 2.6 milligram per meter square, or rather give them a break and let the counts recover and then initiate at the same dose?
It definitely depends on the degree of decrease of the counts that we're seeing and sort of the clinical implications. When you think about neutropenia, that's important, but really what is most important is there clinical significance? Was there febrile neutropenia? And on the trial, the rates of febrile neutropenia were very low. And the rates of infections, grade 3, 4 infections was also low. So I think that is sort of the most important piece of that. But certainly in the trial, there was sort of the median treatment duration with the combination was actually double that of Atezo monotherapy. So AEs that develop during treatment can be managed with dose hold and dose modification. I think it depends on how the patient is doing. For low counts, despite G-CSF, that would require a dose hold and then certainly require a dose reduction. And I think, when you look at the trial data, we did see that there was higher rates of dose interruptions or modifications. It was 38% with Lurbi plus Atezo compared to 13.8% with Atezo monotherapy. Again, same thing for the fatigue. I think for the fatigue, if patients are developing cumulative fatigue, especially higher grade level of fatigue impacting, their day-to-day life, dose hold and dose reductions can be very effective to managing that.
And this is where art of oncology comes in. I know there's some comfort of managing these side effects because, again, we've been using lurbinectedin as second-line treatment option. Now we're just moving it in earlier lines as maintenance. Okay, so now I'm feeling a little more comfortable in managing these side effects. And for that patient that is in my clinic, I am repeating CAT scans and brain MRI regularly while they're on this treatment. But then, as we're talking about brain MRI, this brings us back to where we started, the patient selection. Stephen, when it comes to small cell lung cancer, CNS involvement is something we always worry about. IMforte excluded patients with CNS mets. In a patient with de novo brain mets who has undergone whole brain radiation upfront and is now starting systemic treatment, is this still a fair approach? And do we have any hint of lurbinectedin having CNS activity?
Yeah, I think it's a pretty critical question. We don't have a lot of activity or a lot of evidence of activity for CNS mets for lurbinectedin. This is not what I would consider a very CNS active drug. And so those patients were excluded from the study. They were also excluded from Empower 133. And I think it's really just to try to keep that patient population very homogeneous, to isolate the question, have as few variables as possible. This is a setting where if patients had brain metastases, I would still feel comfortable with the maintenance lurbinectedin approach, but I would really pursue treatment of the brain metastases with radiation therapy. And so if the patient had those brain metastases radiated, I would feel very comfortable with this approach if they met all the other relative criteria. If someone had small asymptomatic brain mets that were not radiated, we started with therapy, we had a modest response, and then we were considering maintenance lurbinectedin, before we considered that maintenance approach, I would radiate those, I would treat them. And if you look at the IMforte study, patients were allowed to have prophylactic cranial radiation. Not many did, but you could have it, and they allowed for 9 weeks from the end of induction to the start of maintenance, and that's sort of the time frame with which I would pursue radiation therapy if someone did have brain mets. So I would treat them, but those patients, if anything, I think are at higher risk for relapse and potentially more likely to get benefit from a more aggressive maintenance strategy.
In those settings, are you still doing MRI every 3 months, or are you doing it sooner?
I still am doing it every 3 months, yes.
CNS involvement in this particular disease is indeed a challenging topic. Ticiana, another practical implication that we are tied in, especially in community and even in academics, is that the use of durvalumab, because patients are on carboplatin, etoposide, and durvalumab now, the maintenance option with atezolizumab and lurbinectedin. When it comes time for maintenance, are you switching them to atezolizumab, lurbinectedin?
Good question. I think that's a really tricky one because the way that the regimen was studied and showing the benefits was with this combination. So I think if I had in mind that this patient would be eligible for maintenance with lurbinectedin, I would certainly choose the induction strategy with atezolizumab up front and would try to avoid the switch. But I think in certain situations, would I do the switch? I probably would, but I think that, I would rather start with Atezo up front in the induction strategy.
And Rohit, the reason why you're bringing that up is durvalumab being every 4 weeks, whereas Atezo is every 3 weeks, and Lurbi is every 3 weeks. So from the get-go, I think that you and I have chit-chatted about this as well, that in my practice from the get-go, you're having that discussion saying your whole treatment paradigm is chemo immunotherapy induction, and then you're switching to that maintenance phase with Lurbi immunotherapy.
Well, before we close, we can go around in this virtual circle to gather our key take-home messages here. Isabel, I'll start off with you here. Any take-home messages, and then I'll move on to Ticiana and Stephen.
Yes, I think that, as I had mentioned when we started, we have 3 options for patients with extensive stage small cell lung cancer. All of them are great options. But I think with this data, it's exciting to me. We always worry about relapse in that maintenance phase. And if we have something that could prolong someone's progression-free survival and overall survival statistically, I think this is definitely a regimen to consider for the right patient using shared and informed decision-making always.
Indeed, it is the new standard of care, and patient-shared decision-making is always the key. Stephen, your take-home messages, sir?
One thing that I hear concern about with the maintenance approach is why not just save this to second line? And I think the big thing here is that there's a huge amount of attrition in small cell lung cancer. And if we look at the number of people that get any second line therapy, it's a little bit less than half. And so the point of this maintenance strategy is to give a treatment before progression, to try to prevent progression, be proactive, and give our patients more time. That if we wait until progression, that 50 to 6% of patients will not get any second-line therapy. Despite tarlatamab, lurbinectedin being available, they won't get any therapy because the act of progression itself can be one that makes people too sick to get any therapy or can be fatal. And so it really is being proactive, moving right into the next treatment and trying to prevent progression, trying to delay those events.
Rohit, we've seen this as a generalist as well, right? Over and over, not just in small cell lung cancer. This is a similar trend that we see across tumor types, where be it breast cancer, colon cancer, even for non-small cell lung cancer, that often the patients are not exposed to that second and third line active treatments.
Indeed. Ticiana, your take-home message here.
Yeah, I think I agree with Stephen as well as Isabel. This has been an important gain for our patients with small cell lung cancer, now already included in the NCCN guidelines, is a standard of care for first-line maintenance. And I think the only thing I'll add is, having the patient voice and making sure that we review this option with patients up front before even starting induction so that they know what to expect for the course of their induction treatment, as well as be prepared for maintenance, where we're talking about introducing lurbinectedin first-line maintenance in combination with immunotherapy, and explaining that to them in ways that they can understand and make their choices. I think for the majority of patients, this is a treatment that, we are going to be discussing, and I think patients are going to be interested in it. Obviously, there are some patients that may not be eligible, but I do think it'll be a small percentage of our patients, as long as we optimize their care and work in a multidisciplinary fashion to get them there.
Absolutely. That shared and informed decision is so important. And as medical oncologists, we acknowledge that small cell lung cancer is indeed a devastating disease. But these are exciting times as we're seeing improved overall survival and our patients are living longer because of these interventions. Stephen, Isabel, Ticiana, thank you so much for taking the time to go through the data in hand for small cell lung cancer with us today. For our listeners, let's just go over a quick recap from today's discussion.
In today's discussion with Drs. Isabel Preeshagul, Ticiana Leal, and Stephen Liu, we had a chance to take a deeper dive in treating extensive stage small cell lung cancer, particularly focusing on IMforte given its overall survival benefit. We have seen more than doubling of PFS and close to 3 months of overall survival benefit here with hazard ratio of 0.73 with lurbinectedin maintenance with atezolizumab.
Rohit, one thing that kept coming up was the importance of overall survival here because small cell lung cancer still remains an aggressive disease. Besides this, we also touched on the importance of prophylactic use of growth factors to help with neutropenia. getting comfortable in managing side effects that come along with our interventions so that our patients can stay on these treatments for longer safely is equally important. Thanks for joining us. Make sure to check out our other discussions around recent approvals, treatment algorithms, and challenging cases. We are the Oncology Brothers.